Hello everyone, and welcome to the CoROM Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This week we have another presentation from our Medicine in the Mediterranean conference that we hold every January in Malta. Here is Dr. Sean Bilodeau as he walks us through a few pre-hospital cases he has dealt with over the past couple of years.
Okay, so I'm the one talk between you guys and the next coffee break. This is me, Sean. I'm a ER doc from the States. I work up in Maine. We'll show a map up in a minute. I have no financial disclosures other than I brought my 4-year-old to Malta. This is what I'm going to try to talk about today. So we're going to look at needle thoracostomy, finger thoracostomy. I'm going to give you kind of my perspective on this and why this matters to us in the services that I work for. We're going to do this with some cases, some pretty cool CAT scans I was able to grab. And we're going to try to apply some evidence-based medicine to needle decompression. It's tough to do, but we're going to try. The group I work with, we're currently working on a study right now to try to figure out how to teach the skill. And we'll talk about why that's important as well. And then hopefully come up with some sort of framework about what we should actually do in terms of needle decompression. This is kind of me, and this is why I was able to talk about this stuff. I am an ER doc, and so we do medical school, 4 years of emergency medicine residency. I was at Brown, which is in Rhode Island. I worked ground critical care transport. We do doc medic, doc nurse, two teams. And I'm currently the EMS fellow, which is when you go to medical school, residency, and then decide to continue getting no money and work for an extra year. And I focus just on pre-hospital medicine. So I spend 80% of my time in an ambulance or helicopter, and I work the other 20% in an ER. During residency, I also got my FOM, and so I have like that wilderness background. And then I'm currently doing the master's program here at CoROM. I did one of the eye care courses in April and how I kind of learned about what this space is. And it's that really beautiful mesh of critical care, wilderness medicine, EMS. And so I'm kind of like diving into that as my career. This is where Maine is, by the way. It's way north. It's currently very, very cold. Like I got a call from a paramedic today that the blood in the IV was freezing when they were trying to put it in on a patient. And then Rhode Island is this thing work. It's very tiny little state right here, which is where I did residency. So mostly in like the Northeast. In the States, and particularly in my space, we have two different types of EMS systems, sort of three, but really we have a 911 service, which is like, hey, I need help, call 911, and then the ambulance shows up. And then we also have critical care transport, which I know some of you guys folks work in that space. It matters because our protocols are all over the place in the US. And so what state you work in, what group you work for, are you critical care, are you paramedic based, are you AEMT based? It changes what protocols can do or what protocols you are working under. And then in Maine, we're state-based protocols, meaning that every paramedic in the state functions under the same set of protocols. And then we carve out these little pieces for critical care transport and say, you're kind of special, you get to do other stuff. So as it pertains to needle thoracostomy, really when you talk about finger thoracostomy, we're talking about carving out these spaces, and our critical care services are starting to do that. I want to just put this up real quick too, because I am not a surgeon, and you will find in the papers, if you look at this thoracostomy, thoracotomy are interchanged. We're just going to call this a needle thoracostomy or finger thoracostomy. We're also going to just say that needle decompression is what we guys do, right? We put the needle into the chest, and then anything that goes in the pleura, we're going to call that pleural decompression. So this is my world. Most of what we do in my systems is blunt trauma. Sometimes we're seeing penetrating trauma. In different cities, we're seeing more of that, but most of what we're seeing is actually blunt trauma. And so that matters because we really know that penetrating trauma and causes holes in lungs, and you can fix that pretty easily. Blunt trauma is a lot more vague for the paramedics to figure out on scene. And so it's not as simple, oh, there's a hole, put a chest seal on it. It's a polytrauma, and we're trying to listen to breath sounds with sirens going and people screaming. And so the idea that you can listen to breath sounds and figure out if there's an issue is kind of moot. And so I just kind of want to say that that's my preference, or my perspective, is we're just mostly blunt trauma. This is what we have. I have no connection with North American Rescue or anything, but these are mostly what people carry in the US. You either have the ARS, which is the kind of one I have the pointer on the right here. It's 3 1/4 inches, which is I think 5 centimeters. We have the Spears, which are 5 inches, which makes it 9 centimeters. And then this is just an angiocath, a 14 gauge. And so this is what our crews are carrying. Going back to thinking about why paramedics are doing this procedure, it's because they have suspected tension pneumothorax. And they're taught that if you don't have breath sounds and you're hemodynamically unstable, you're concerned for tension, and so you decompress the chest with one of these 3 things. The vast majority in the state of Maine anyways, the needle decompressions that we're seeing done are on trauma codes. And so meaning that there was a blunt trauma, the patient is in extremis or dead, they get needled on both sides, patient goes to the hospital, and the vast majority of those people die. And so that happens. The problem when I'm teaching paramedics is that I have almost no feedback about whether the needle was correctly placed or not. And so paramedics are doing the procedure, and they're doing it, perceiving that they're doing it correctly, but I have no way of following that up, because almost always, if it's a trauma code, you get to the hospital and we just call it, we do nothing. Or you get to the hospital and you're in extremis, we rip the needles out and then you go to CAT scan. So I actually have no clue whether you got into the pleura or not. So we're gonna talk about some cases, 3 of them, where we actually have some nice imaging and try to understand what exactly it is that we need to teach paramedics on how to do the procedure and do it correctly. And the basis of our research study came up because I work for Portland Fire, which is an urban 911 system. The paramedics, they want finger thoracostomy because it's really sexy, right? And then I also work in the ER, and I have other attendings saying, why are paramedics doing anything? They keep hitting the wrong spots. And so I have these 2 competing interests. I have paramedics who are really, really highly skilled and they want to do the cutting edge stuff. And then I have non-EMS based physicians saying, you should not be touching that patient because you keep sticking the liver or sticking the heart. We put it in the wrong place. And so we have these competing views. And so we tried to do a case series and figure out why those views happen. Quick disclaimer, all of the CT imaging are mine, the patient image is mine. I have some kind of like fun internet stuff I grabbed for other photos. And then I also want to just point out that I grabbed 3 cases with good CAT scan findings. This is not a representative sample of every paramedic in Maine, every paramedic in the US. All right. So first case, 61-year-old guy fell 30 feet off a ladder onto concrete. EMS crews find him to have diminished breath sounds bilaterally. They did bilateral anteriors, bilateral lateral, needle decompression. He goes into the ER. This is just a single cut of the lung view of his chest CT. And so just so we're clear, kind of laying on the table, back's down here, head would live up here. This is the heart in the lung view. This is all lung parenchyma. And then this black stuff is air, right? So right side, still a pneumothorax there. Left side, pneumo there. Worse on the left. So this is an axial cut. This was one we got to leave the needles in. So we're going to talk about where those go. So this is the right-sided anterior needle. This is the pleural line right here. And then you can actually catch, that's the hollow point, and this is almost the bevel. So we did not make it to the pleura on that one. This is also an axial cut of the lateral left, this little tiny thing right here. And then this is a better picture. So this is a coronal cut, right? So you're seeing the needle, this is the bevel right down here. And maybe hit the pleura, but probably not. And this is your lateral on the right. Yeah, whoopsies. I'm sorry, I try to move so you guys can also see CAT scans over here. Yeah, so again, coronal cut, needle, You can see that the hollow point, and then we're in the pleura. We definitely hit the pleura. We also hit the liver though, and this is the axial cut of the same needle, and this little bright spot right here is the needle tip inside the liver. So this guy does fine. He gets 2 chest tubes, and he goes to the trauma ICU, and he's there for like a week or so, and he goes home, and everything is great. But this brings up this idea. People are like, well, why are you shouldn't be doing needle thoracostomy or finger thoracostomies. You can't even get needles right. We can't hit the pleura. We're hitting the wrong place. As it turns out, you can put a 14 gauge needle into the liver and you're fine. But it brings up this idea, like, how do I teach medics, or how are we doing the procedure? And then I will ask for a volunteer. If anyone's a paramedic, especially in the US, what's the answer on the test about where you put the needle? Is like a quote? Right, 5th intercostal anterior axillary line or 2nd intercostal midclavicular line, right? Everyone, like, that's the answer, right? I will challenge you to put your finger there. And that's what we're finding, right? So in every one of these charts, and we'll look a couple more. This guy's 45. We got called, he has a history of bipolar, and he was suicidal and jumped in front of a car. So he's found by the paramedics, looks very unwell, obviously polytrauma patient. And so they listen to his lungs and find that he has no breath sounds on the left. They placed an ARS, and so I will read the quote from the PCR, which is our run reports. ARS placed 5th intercostal midclavicular line. Yep. That's a picture of him when he arrives to the ER. Probably don't need the pointer, but that's the ARS. That is the left nipple. It is definitely in the midclavicular line, or close, but we are way low and way anterior. So bright red blood comes out of this. Paramedic did a phenomenal job because they put a stopcock on it and just left it alone. It's like, I wish I didn't do that. Go to the ER. Will this play for us? Let's see. Oh yeah, okay, so this is the CT. And we're keeping an eye right up here. You're gonna see bright, yep. Do we wanna do that one again, or do we see that? Here. And so again, looking up here, looking for bright white, that's coming in, and that's the left ventricle, right, with contrast in it. The 3D reconstruction of the same thing, and that's the ARS down here, and this is obviously the left ventricle. So this guy also does okay, but he ends up going to the OR. He gets a sternotomy, he gets a pericardial drain placed. The catheter had actually come out of the ventricle by the time they got to the OR. They had to stitch the ventricle, stitch the pericardium, bilateral chest tubes, pericardial drain. He was in the trauma ICU for a while. He's actually, this is relatively recent, he's currently in an inpatient psych hospital and doing well physically. He's still working on his psychiatric stuff. This was one where I got an email, why are your paramedics doing this again? And we're gonna do one more case. So this guy's 47. He had fallen off a ladder 6 days ago and then had somehow got into a kerfuffle with police. And so we're actually getting called to jail where he's reporting shortness of breath and some chest tightness. EMS listens to him and says he has no breath sounds on the left. They actually did an x-ray at the jail, and the EMS provider, the paramedic, was told that he had a pneumothorax on the left side, and so kind of had some bias walking in. So puts a needle in the left chest, and the PCR report will tell you that the SATs improved and the patient felt better. This is an x-ray, and so this is the needle right here. You're seeing it's actually obscured by the cardiac lead, but when you go to the CAT scan, it's even better. So that's the coronal cut. Obviously the needle. I will point out that whoever read the x-ray was way off. That is not a pneumothorax, it's a hemothorax. And so we're seeing the needle there is really not even close. And then the axial cut. And again, bevel right here. I will give the paramedic, I will give every paramedic credit always, because you're doing a job that I get to look at CAT scans. You have to do this without a CAT scan. There's actually, I think, I have no way of proving this, I think this is actually a tract here. And I think that needle probably did enter the pleura and got pulled out during a move. I know the medic, he called me like 20 minutes later. He was like, the CAT scan said it wasn't in, I swear that thing was in. And it may have been, but it certainly wasn't still in. This guy also actually does just fine. He goes to the ICU and gets a VATS because that's actually an old hemothorax from the fall 6 days ago. Had to go to the OR, get it all kind of washed out. He's currently on the floor, or I'm sure he's home now, but when I built this last week, he was on the floor doing just fine. And so these are the cases I get emails about because we keep hearing people saying paramedics probably shouldn't be needle decompressing because all of these things happen. I'm staunchly against that. But how do we figure out if this actually works from an evidence-based standpoint? Because someone say like we're in academia, like I need double-blind randomized controlled trials to do anything. But this stuff is really hard to study also. So we're finding that I have really phenomenal paramedics that really want to do cutting edge care, and we need to teach them how to do it correctly so that we're not hitting the heart or hitting spaces we're not supposed to be. And I think my thought is we need to get rid of this. This second intercostal midclavicular line, fourth or fifth intercostal anterior axillary line. Anatomically, it's correct. I cannot find someone who can put their finger on it who hasn't spent 2 years doing anatomy, right? Like we can talk about this as physicians because we do this. We spend a lot of time figuring out where that is. Our paramedics, unfortunately, the vast majority of them in the States don't get hands-on anatomy with a cadaver. Some systems do, but there are very few. And so we need to figure out how to actually teach this. And we also have this problem, right? Things fail. Maybe those needles got into the pleura. I don't know. And then it brings up this question, is there a better way to actually do this? And so I have 3 clinical questions that I kind of want to use some papers to talk about. The first one is like, should we do this at all? Yes, we should. And here's the data to tell us why, right? So this is a really interesting study. It's a cohort study out of Pennsylvania looking at 8,500 trauma patients. And this is one of the few studies that actually had a control arm. And so if you'll find EMS research is incredibly hard to do because you can't just do one intervention because and add sick people. We're doing a lot of stuff, and randomizing in the pre-hospital environment is incredibly hard. You have to like put up billboards and send out these things that, hey, you might be assigned to this particular group if you have a cardiac arrest in this town or whatever. So it's really hard to get done. This study did a wonderful job because there's a control group, and what they did is they looked at the control. The control group was anyone who got a chest tube within 15 minutes of showing up to the ER. And so there's one group is, hey, they got a needle in the ambulance or before they showed up. The control arm is, hey, they got a chest tube within 15 minutes, meaning they did it before there was any imaging. So the authors said, well, that group of patients that got a chest tube within 15 minutes would probably be a group that could have benefited from getting a needle or a finger in the field. And so this is the adjusted odds ratio comparing the group that got a needle and the group that got a chest tube. And every single one of these things has an increased mortality, about reduction in mortality. So our pre-hospital needle decompression group, they're doing better. And they do better just being alive. They do better if you match their ages and their traumatic mechanisms and their past medical history. They do better if you even take out some people that got a severe head injury. They do better if you take out the people who died, and then they still do better if you add the people that did die, which this tells us that we have data saying that we should be doing this procedure. And so this is when I have attendings come up to me and say, why are your paramedics doing this? Like, this is why we're doing it. It saves lives. And if you look at this group, 8,500 people, of the people that got a chest needle decompression, and then you compare the people who got the chest tube, only 11% of the people that got that chest tube in the first 15 minutes had a needle. That means that we're doing it infrequently. And even though we do it infrequently, we still have a huge benefit. So the procedure is good, right? Like the treatment works. Evidence says that we should be doing this. And so now the next question is like, do we do it anterior? Do we do it lateral? Our medics, I'm finding, are much more comfortable anterior, and I don't know why. I think it's probably because ATLS, version 2 or 3 ago, didn't really include the lateral. I learned it, and we learned both, but So most of our paramedics are doing anterior. And so there's 2 quick studies here. This is just a quick plenary study looking at if in cadavers, which side should we do? So this group, they trained 25 Navy corpsmen. Everyone they got a little training, and then they decompressed anterior and lateral on both sides. So every person did it 4 times. So 25 people 4 times. So everyone got like a lot of experience doing it. And they found that it's actually subjectively, the people said, oh, it's easier if I go lateral and it's faster. They timed them. It's a little bit biased because they got training and they did 4 of these back to back to back to back to back. And so it's hard to say that that's something that you're going to do, once in your career, once a year, but they're saying, hey, the lateral is probably easier. And then same group looked at same idea, going to put needles in, and these guys put anterior and lateral needles. They used a 14 gauge angiocath, and then they did a thoracotomy, and they looked, is the catheter in the pleura? And this is the results they got. And so laterally, every single needle and catheter made it into the pleura. Anteriorly, a little over half. And so these are some of the papers that we're looking at saying like, hey, maybe we should be doing this laterally because our success rate is higher and our failure rate is lower. The problem is I can't teach people to put them in the correct place. And so last clinical question, needle or finger? So in the state of Maine, there's 2 EMS physician response groups. One is a attending-led group kind of in like central Maine. I'm the EMS fellow. And so like there's two groups that'll even do a finger. The critical care transport will do it, or they can do it. They never have. It's something like if I go on a trauma, I'm doing a finger thoracostomy because I'm an ER doc and that's what I know how to do, right? And I know that it feels better, but is there data to say that? The answer here is also yes. So this is a small study that's based out of San Antonio, which is an incredibly progressive EMS system. So these guys looked at needle versus finger thoracostomy by a ground service. So we take out the HEMS folks. This is actually a 911 service. It's not a critical care service. But the people who are doing it are in like a response vehicle. So they're in like the paramedic fly car. It's not every single paramedic in San Antonio. And so these guys found, again, the N is very small, but if you look at the finger thoracostomy versus needle and everything, so, p-value below 0.05, obviously, right? So our decompression is better with the finger. They get less chest tubes, which is a little interesting. There's no difference between the thoracotomy, which is like you go into the OR, crack the chest, or go into the ED and we crack the chest, neither in the ER. There's, technically speaking, there's a reduction in thoracotomy in the OR, but there's no mortality benefit. And part of that is probably because our patients are so sick, we can't actually tell, is this the one thing that saved them? But this does tell me, hey, I'm getting decompression better with a finger. They're highly skilled paramedics who are training on cadavers. San Antonio is one of the places that does have that. And so we are seeing, hey, maybe I don't have better mortality because my N is too small, but I do have better pleural decompression. So that hints, hey, you probably should be doing finger thoracostomies. All right, so what does that take away? So we need to do this, right? And I'm speaking to a group of people that does this. So but there's evidence to say that we should be doing this. I've been shocked at the amount of times people, not from this community, but from EM-based communities will say, why are we doing this? We keep screwing it up. Because they don't see the 85 other needles that went just fine. They only see the 3 I showed you. We should definitely be doing it for tension. There's a thought, maybe we should be doing this for people who have vital sign derangement with blood trauma. Because listening to your lung sounds is completely useless on the side of the road. The ultrasound is lovely. We're struggling to get people credentialed to do a lung ultrasound as a paramedic, but I carry one, but if we can get there, we should be doing that. The lateral approach, probably better. Based on the cadaver studies, there's no better evidence out there, but we probably should be doing it laterally. And finger thoracostomy is probably more effective, but we need to keep looking at that. I also consult with the U.S. Customs and Border Patrol. They have an austere paramedic it's like a special forces group. It's called BORSTAR. I help teach their BORSTAR training, which is basically like we go to San Antonio and we practice all this stuff on cadavers, and it's like probably the coolest thing I've ever done, except for bring my kid to Malta. And so their CPG says you do anterior. If that doesn't work, you do lateral. And if those don't work, you do a finger. And then this is the TCCC, which you guys are all very much aware of. And so I actually really like this because it says do whatever you can touch first. If anterior is closest, do that one. If lateral is closest, do that one. If it doesn't work, do the other one. And then if those don't work, put a finger in it. And so what we're trying to figure out based on this is like, hey, we know we should do this. We know we should decompress the pleura. We think it should be lateral. We think it should be a finger thoracostomy and not a needle. It'll fail less. But I'm having a hard time, like I said, teaching paramedics somewhere to locate it. So what we're currently doing, we're surveying all of the educational facilities like in northern New England and asking, hey, how do you teach this? And not what are the words you use, how do you hands-on teach people to do it? I have a whole bunch of, put their hand in the armpit, I have a hook the sternal notch with your finger, I have SAM, like Sam Swift makes a little yellow card. There's an abstract at NEMSP that's showing that's probably gonna work, but no one's ever studied it really. And so we're taking all of these ways on how people are being taught, and we're gonna teach them. And then we're gonna teach our medics. The medics are then gonna do that thing and mark a bunch of different patients. They'll be like fake patients, right? So they'll get marked, and then that person will like leave the firehouse and go get assessed by a trauma surgeon and an ultrasound doc and a ER doc and say, hey, did you hit that triangle of safety, right? Are you in the correct place? And when we figure out, hopefully, if there's a method on how to actually teach this, then we can teach paramedics to do it. Because I don't think that those words work anymore. And so if we figure out, hopefully next year I can come back and tell you like, here's how you should teach this. I just don't know what the answer is yet. I know that we need to teach them better because I'm getting all sorts of random things. So we're currently doing that. It's kind of like a 3-phase thing. Part of it is the case series, and then we're in our IRB approval now to figure out which thing actually works. So if you guys have other cool things that I don't know about on how to decompress, I would love to hear them. All right, so in conclusion, decompress the chest, probably laterally, probably with your finger. And also remembering that there's another part here we didn't really speak about much is that catheter you do with the needle comes out a lot. And so I still don't know how to effectively attach those things because I can't teach paramedics to stitch because that's not allowed, right? And so we're having them taped down and like jerry-rigged to try to figure out how to keep them in. And so part of it, I think, which we don't have evidence for yet, is that the finger thoracostomy prevents the failure of the catheter. I just don't know that yet. Okay, any questions?
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at corom.edu.mt.